This is Roger Green, host of the Surfing the NASH Tsunami podcast. This weekend, we are offering 4 conversations from Season 3, Episode 45, our review of the recent Paris NASH conference, plus, from the vault, conversation from April 22, which looked at the need to improve testing criteria for drug development. These conversations are running a bit behind our usual schedule due to the challenges of travel and time change surrounding the NAFLD summit that ended in Dublin on Saturday. We'll be back on our regular conversation drop schedule next week. And now, on to the discussions. This week, our conversation from the vault comes from Season 3, Episode 19, with Stephen and Mazen Noureddin as the co-sponsors of the NAIL-NIT initiative, joining Jorn, newly anointed as a permanent co-host, Naim Al-Khoury, Louise, and me to discuss the NAIL-NIT retrospective analyses. The first part of this discussion focuses on the idea of morphic resonance in liver disease. The gestalt tells the research of the disease is present or a drug works, even when there is not clear quantitative data to support that impression. Louise then shifts focus to ask whether we can use some kind of patient questionnaire to analyze patients and provide screening data before you actually bring people into trials. Naim Al-Khoury is enthusiastic in thinking about this as an idea we should pursue further. Reviewing this conversation reminded me of how much progress our community is making on holistic, integrated treatment approaches and insights, even in the absence of an approved medication. It's inspiring. So sit back, listen, enjoy, learn, and when you're done, join the dialogue on our LinkedIn discussion group.
Stephen Harrison.
Some of the comments you made, Roger, are really simplistic in tone, but they're very complicated to unpack and unwind. So dating back to the advent of the FDA getting into the business of finding a drug to treat NASH, we had to come up with something. We came up with some histopathologic criteria that had modest outcome data linked with it, particularly NASH resolution. And fast forward now to where we are, and we realize that those criteria are challenging to hit consistently for lots of reasons. Heterogeneity, inter- and intra-observer variability, the size of the biopsy, the staining that goes with it, the processing that goes with it, the shipping it all over the place. Some of those we've fixed, some we haven't. And now we're left with trying to come up with a better test, a non-invasive test, that we can't go back to where we were 15 years ago and just pull a marker out of the air and say, this is what we'd like to study. The authorities have said, well, it needs to link to an outcome, despite where we were when we came up with the histopathologic criteria. To me, it's a bit like this phenomenon of morphic resonance. Have you guys heard of that? Morphic resonance. It was written by a guy named Rupert Sheldrake. He's an English author, Louise, just to let you know. I think he's from Cambridge. Yeah, he's a Cambridge-trained guy. So it pains me because, there's Oxford and there's Cambridge, right? But morphic resonance is the idea of mysterious telepathy type interconnections between organisms and collective memories within species. And he gives examples of this. How do dogs know when their owners are coming home? They're in the window barking and you hadn't even turned the corner yet. Or phantom limbs. So somebody still feels their limb is attached even though it's been gone. And it's a little bit like that with where we are in the field. Naim, you highlighted, we know this patient has bad disease. They're F3, they've got architectural changes that are consistent with a NASH phenotype, but yet we just can't bring ourselves to call it NASH by our current definition because we can't find the rogue ballooned hepatocyte. But we know it's there. I think part of this is just kind of resetting, taking a step back, getting back to Louise's comment earlier, keep it simple, stupid, the KISS principle. We know these people have disease. When we did a post hoc analysis on the Intercept's Regenerate trial, I'll never forget this, when we were putting together the data that Zobair Yonasi presented on the phase 3 data. We said it didn't hit NASH resolution defined by ballooning of 0, inflammation of 0 to 1, but if you look at a gestalt definition of NASH, it did hit stat sig. So here we have pathologists saying, if you just let me look at it, just like Naim just did, if you just let me look at it, this is NASH. But if you apply strict criteria, the ones that we came up with, it wasn't NASH. That is what we need to get beyond. And my hope is that these NITs, these non-invasive testing strategies that we bring forth, whether it's the diagnosis of at-risk NASH, prognosis, or measuring therapeutic efficacy, that we're able to apply a certain amount of reason to it and understand that no test is perfect, but where we are able to define a reasonable sensitivity and specificity, that's what we take forward. And know that there's not going to be one single NIT that addresses every one of these questions. And that's the beauty of having Naeem and Jorn and the entire steering committee involved with the process, because each of us brings something unique to the table and a different perspective that could be applied toward the various NITs that are out there, whether that's MAST, MEFIB, FAST, Agile 3, Agile 4, NIST 4, you name it. Or something new, Pro-C3, ELF, combination of all of that.
What happens next on this path?
Jörn Schattenberg.
Yeah, I think as Stephen said, we aim to fill the gap that is left behind or left open by the big consortia, Nimble, Litmus, and really trying to understand, based on the data that's there, explore the aspect, as Naeem said, where do we have the discrepancy? How can we, with the available data, close that gap? Or inform Stephen and Mazen and say, well, I think, in the prospective part, you should really have a look at this, because we found this is the reason why we fail in a significant number of cases, or inform them on certain patients that do have more specific characteristics. Stephen has done that extensively, but pulling this all together, I think the power is just going to go up, and maybe even apply some sort of artificial intelligence technologies, get a partner in that looks at the data set and informs us on how to make NAIL-NIT move forward. That's from my perspective. That's how the retrospective is going to support the project.
Louise Campbell.
Can I ask you a question? The data that's being collected, obviously, particularly for the retrospective, does it go as in-depth as people's presenting symptoms, what they regularly presented to the primary care physician with? Because if I look at it as a whole, NAIL-NIT, if we go backwards, should, with the numbers of patients, be able to bring us down to a questionnaire, a formation that somebody can fill in a primary care physician's and say, you are more likely to have this. These are the non-invasive that we would suggest because you scored X on looking back on that, so that we can actually nail the right NITs for the right presenting symptoms or cohort symptoms in each of the individual sort of phenotypes coming through. Do you think that's possible from combining all of you guys work with Litmus and all of that?
Naeem Al-Khoury.
That's why we love having you on the show, Louise, because you just gave me a great idea. Most of the data is generated in the context of clinical trials, but they have actually quality of life questionnaires, and it wasn't even on my radar, but now I'm going to look into it and see, because often we use the same ones, and there are a couple that were developed for other diseases. There are some specific ones for chronic liver disease and NASH specifically. So yeah, we would have to look into this and actually do it the way you said it. Look at the quality of life questions, what are the issues they're dealing with, and then look at the NITs, look at the phenotype, and see if we can actually come up with a specific set of NITs for specific presentations. I love this idea.
Mazen Nureddin.
I love that she gave you the idea, and I love the fact that you guys are so far committed to 8 papers from what I'm counting.
But I think the whole point is most people that get to a trial are the very few of the very few of the very few, and we want the whole of the pie to be diagnosed. And that's in a primary care setting.
Stephen Harrison.
I have to brag on Naeem for a minute. This guy has 2 little girls. He has a clinic in Cleveland and a clinic in Phoenix. Like, for those of you who don't know geography in the U.S., they're not like right next to each other. They're like a long way away. And this guy has the ability to crank out a wonderful paper in a weekend. Like, I'm just going to sit down and just put something together. And it's like this beautiful prose that just happens. And what takes him a weekend to do might take me 6 months to do. So you might get your 8 papers, Mazen. And Jorn is very critical, and he looks at things through an eye that I don't have the ability to do. So the 2 of them, just, 8 might not be near the ceiling.
Thank you,
Stephen the whole thing is just like he wants to increase the 8 to 10 and 12. They're coming by the end of this show.
Yeah, I don't know where to take that, since I'm a painfully slow writer, and I've never written an academic paper in my life.
It just struck me. Jorn, you have 2 girls too,
Yeah, that's
right?
Yeah.
So all 3 of you guys, 2 girls each.
Yeah,
Actually,
that's a funny coincidence.
If I count in this one, I also have 2 girls. So that would make 4 of us,
Is that
right?
true? Oh my God. Listen, I love my girls. They're the world for me. And yep, I'm all behind women power. I have to tell you, my 40 years old went to the market, and I'm sorry to hijack the talk, here in Spain. And what's that thing, like the flamingo high heels? She goes and grabbed this flamingo high heels for kids that is pink with black dots on it. And she's trying to dance flamenco, 4 years old. And she's wearing those 24/7, including going to bed.
And I bet you've got some great video.
Indeed.
That's amazing. Remember those moments.
Yeah.
The other saying I'll say is that days drag by and years fly by. Just remember that when they're 18 and leaving home.
Or when you spend the weekend with your roughly twice that age and her 2-year-old son who's named after your father.
Yeah, no doubt. No doubt. Good memories.
That was last weekend. It just keeps moving. So let's crystal ball for a minute because it's fun. We're here in a year, and then we're here in 2 years. What do you think will have come out of this work? What do you hope will have come out of this work? And how do you believe it will shape the prospective trial and the other things that people are doing outside of NAIL-NIT?
Well, let me take the global view, and then I'll turn it over to the smart guys. What I want to see come out of this is something that is crystallized, a better idea of the right roadmap for how to evaluate patients with fatty liver disease. Because right now, there are any number of different pathways that you can look at, guidance documents that are out there, and some are similar, some are dramatically different. Some start with a blood-based biomarker, some start with an imaging biomarker, and if all we do is validate one of those current paradigms that we can simplify and spread throughout the world on this is the best way to go about diagnosing this particular patient cohort, that would be my dream and my goal.
And now, back to Roger.
We hope you enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please send an email to questions@surfingnash.com. We will be back next week to discuss some recent exciting drug trial results and what they portend for the next couple of years in drug development. In the meantime, stay safe, surf on. We'll see you on the podcast. Bye-bye now.